My record. Okay. So we will record this and then we will put it on the NHA website. The other thing, people were willing to share some of their policies and procedures through just some changes they've made throughout all of the regulatory adjustments. So we will, with the permission of those organizations, share those and we'll see if they want them blinded or whatever. But we will make what we can available to those of you that are still kind of in the midst of writing policies and procedures for these new changes. So the beginning part of this kind of webinar is going to be related to those changes in regulation. And if you all remember, they are staggered and when they go into effect. So the first couple will go into effect July 1 of 2025, so like in 6 weeks. So those will obviously be the ones we'll want to focus on mostly today. And then we did the gap analysis for those of you that were able to get that back to us. We appreciate it. And it just it went through all of the changes just to prepare you for what's to come. And then it also talked about the severe hypertension bundle. So we will talk just about the pieces of that. That is not regulatory driven, just to be really clear. There's these bundles that are made from a safer birth organization. They basically talk about best practices and how to decrease maternal morbidity and injury in pregnancy. So these are just best practices. And MPIC, who is our quality group for the whole perinatal time frame. They focus on kind of one specific bundle at a time. And this is one of the new ones that they were focusing on. So we just wanted to kind of give a little bit of background into that for anybody that might be interested in implementing those bundles. There's toolkits and all sorts of things that go along with that. But as they are the experts, the true experts in the maternal safety space, we just want to make sure that we partner with them and help if there are things that we can do to just help collaborate with all of you that are delivering babies out there still. So that's kind of I think the background on what's going on today. Please keep your line muted unless you are going to ask a question or give us a comment, which we would absolutely love. We want to hear from you guys. This is time for you to share with your peers and talk about any barriers you've found as you've moved through this. So we will get started. Okay, so the why behind the what, which we talked about this on the first webinar, but there is, the US has one of the highest maternal mortality rates, especially for a country with a high income. So there have been a lot of discussion and efforts to address these issues. And some of them now are becoming regulatory driven. So the new requirements for the OB services are necessary to protect the health of the pregnant and birthing and postpartum patients. Now, the final rule came into effect in December of 24. The very first couple pieces will be effective July 1 of 25. However, I have not seen any guidance around it. Usually when there's new regs that come up, there's a lot of guidance around it. I have not seen much of that, which some of that might be just changes in administration and different changes, but I have also not seen that they're not going to become effective July 1st. So just being mindful of that. Also, Sydney, who is from MPIC, and she is a great resource, which normally would be joining us on this call, just sent me an email right before that she had a bit of an emergency, so she was not going to be able to join us, but she's always very willing to answer questions and good for outreach. So if there's ever specific questions about this maternal safety stuff, Amber and I are happy to help, but she is also another great resource. Um, So I put the couple first that are going to be effective on July 1st. So we talk about the emergency services conditions of participation. This one is pertinent to all hospitals that have emergency services. So PPS, CAW, even if you're non-delivering. So being mindful of that when you look at this, and really the idea about it, or the idea behind it is that a facility will be prepared to care for a pregnant, birthing, or postpartum woman that comes in an emergent situation. So it's basically being emergency services readiness is a piece of this. So the specific kind of things that they looked at are protocols consistent with the complexity and scope of services offered. And now they talk about aligned with nationally recognized evidence-based guidelines. So essentially what they're getting at is if you're going to just package and ship, most likely, if that's the complexity that, you just have to have those emergent things in your emergency department that will help you stabilize and then ship that patient to the correct level of care. Um, they say including but not limited to OB emergencies, complications, and immediate post-delivery care. So I always think about the non-delivering hospitals that have, a pregnant person walk in and deliver in their ED. Are you prepared for that? And then it's talking about being able to articulate the standards and sources and to demonstrate the standards are based on evidence and nationally recognized sources. There are tons and tons of toolkits, evidence-based practice out there. So you just want to make sure whatever you do is based on something that is considered a recognized source. The other piece of this is training for your staff. So you implement all of the hold on, I got people coming in here. There we go. um, protocols that they ask, but then you also have applicable staff must be trained on the protocols and provisions annually, and a documentation to prove they have successfully completed training and can demonstrate knowledge. So again, don't just have them sign off. You need something that says they demonstrate knowledge. So whether it's a post quiz or if you do a hands-on competency that you sign them off on, there has to be some documentation that, and when it says applicable staff too, you have to think about, is it everybody that works in your ED? In some smaller hospitals, it might be all of your nursing staff. So just making sure that you have a way of determining what applicable staff is and how you will document who is considered applicable staff. And then there is a piece in it that hospitals must have emergency provisions, including equipment, supplies, and medication. So they never actually define what it has to be, but you have to essentially have something pulled together for those supplies and equipment, and you have to have a list of what will be kept there, and then how you train on, say it's a piece of equipment or a med given. So you'll have to have training on those specific items that you are keeping in your emergency department. They give some broad guidelines below. It does not say you have to follow these, but I think this is a pretty good framework for if you don't have this kind of stuff, where you might start. So drugs, blood and blood products, biologicals commonly used in life-saving procedures, which will all kind of be there. But if you think about how that might be different for a delivering mother, then equipment and supplies commonly used, and then a call-in system for each patient in the emergency services treatment area. So a way for them to contact you if they need something. So again, there's already emergency supply requirement for critical access hospitals. And so this would align with that. You just have to really think about, when you're writing those protocols, what it looks like specific to a obstetric situation. Okay, I'm going to turn over to Amber.
Sure. So thanks, Dana. Just some tidbits from the gap analysis that everyone filled out. We did have about 33 responses, so appreciate everyone taking the time to fill out that very lengthy gap analysis. I am working on a full report on all of the responses. That is taking a lot longer than I had anticipated, so more to come on that, but this is just kind of some snippets from the emergency readiness piece of the analysis. So 40% of our respondents did not have an RRT. Some of the other comments were sharing that they have a multidisciplinary team that includes several departments. One call out was that they were unsure if patients and families can call an RRT. So just thinking through those things that you may not have thought about when you were filling out the gap analysis and you're working towards implementation of these types of policies. 60% of teams did have access to the needed medications and equipment. So that included all of the lists of supplies and instruments and medications that are recommended to have within a near distance. So some of you guys have kits and infant warmers, and that's where all of your supplies are located. Some of them did indicate that they're in separate areas due to storage constraints. So just making sure that you're kind of reevaluating what your processes are currently, and if a surveyor were to ask you, you'll be able to speak to where your equipment is. 33% do not have a massive transfusion policy. Um, so there's very few policies that were shared with us in the gap analysis. So I am going to chat in a Dropbox. If anyone is willing and has that capability to slide your policy procedure protocol into that Dropbox, I would anticipate that many of our small hospitals would appreciate having something to refer to and not reinvent the wheel that some policies are already created. So once we do the full report, we'll include all of the policies and procedures that were shared with us, but this is just kind of a one-stop shop. If you're willing to throw some policies in there for peer sharing, I think it would be much appreciated. 40% do not have OB hemorrhage order sets. So again, if you have some protocols or some snippets that you'd be willing to share, you can throw it in the Dropbox. 50% do not have team-based drills and simulations to maintain preparedness. So like Dana had mentioned, the annual training, do you do post quizzes? Just kind of reviewing your protocols and ensuring that all of that is in place. This is a list here of some of the things that were shared in the gap analysis of all of the trainings that they do on an annual basis. 74% of respondents did not indicate that they have the BSLO and ALSO training for their providers. There was only one comment that said that they do not currently require these classes. So looking into that and seeing if your staffing wants to get trained in those certifications. Next slide, Dana. And again, a lot of the gap analysis is policies, protocols, algorithms. So these were all of the policies that were indicated in the gap analysis. There are a lot of folks that do not have those in place. And as this is something new that's effective here in the next couple months, any peer sharing would be greatly appreciated. And if you don't feel comfortable putting them in the Dropbox, you can shoot me or Dana an email on what your policies look like, and we can blind them for you. Oh, we don't have access to the Dropbox. I think you did have to plug in your email and name. So if anyone has troubles, reach out to me. So I see another comment. The ALSO class is very hard to find. That might be a takeaway for us, Dana.
I've actually
But
heard
again,
that before, and people have asked about finding more. So that is probably something we can maybe help with.
so just to kind of wrap up with this, I mean, those policies and procedures are not something that you can just create overnight. So know that you're not alone. There are several other folks that don't have these policies in place yet. But as you're thinking about your plan to become compliant for this emergency readiness piece of the new things that are happening, just keep in mind that you're not alone and it does take some time. So I think that's all I have, Dana.
And I see in the chat, Samantha King just shared she highly recommend taking A1's new OPS class. And I don't know if you want to kind of off mute, Samantha, and talk about what that is.
Yes, yeah. So we actually have a trainer here at Bryan. Marissa Schaefer is the trainer, and also Tisha Bergmeyer is as well. So essentially, it's obstetrical readiness for hemorrhage, sepsis, hypertension, all the types of things. It's a high level, but we actually have our ED provider, or not providers, nurses take it as well, and they also thought it was a very, very good learning opportunity for them because it kind of gives you the nitty gritty that you need, but it also doesn't make it so overwhelming that you feel like you can't actually do it. So I'll actually drop a little bit of more information about it into the chat, if that's okay. That way people can look into it. But it's similar to also, but has, to my knowledge, it doesn't focus on the preterm piece that also might focus on. But it does give you a lot of evidence-based practice, clinical understanding, and it even brings in the equity piece for all hospitals to be able to benefit from, not just the OB hospitals. So I can send you a little bit more information, Dana and Amber, if that would be more helpful. But I'm trying to find a quick one pager on here, but give me a second.
Yeah, that would be awesome. So if you want to share something there, and then if you have like links to where people might find dates and registration type stuff, I'd be happy to share out that information. Thank you.
Super.
Okay, here we go. Okay, so the other piece that is going, so the emergency piece is one that's going to become effective July 1, and this is the second piece, which is the hospital discharge planning changes, and this is related to transfer protocols. So again, this would be for delivering and non-delivering hospitals. But the reg states you must maintain written policies and procedures for transferring patients, not just OB patients, to the appropriate level of care promptly and without delay to meet specific patient needs. This includes transfers from your ED to inpatient, transfers between inpatient units within the hospital, and inpatient transfers to a different hospital. So it's essentially they want you to have a plan for how you're going to get that patient to wherever it is they need to be to get the appropriate care. I will say that with this being kind of wrapped into the OB regs, it is usually a good idea to at least have some sort of a relationship with a higher level delivering hospital if you need to get a patient to that type of care, just to have a plan for what that looks like. Again, and all of these regs throughout the kind of underlying theme and all of them is you must provide training to relevant staff regarding what those transfer policies look like. And this has to be done annually. And again, you will want to find a way to document who is relevant and make sure you showed that they got trained and that they tested out and said that they were understood or that the training made sense. So right now, it's saying only PPS hospitals have to meet this reg, but I would recommend critical access hospitals follow suit because it often, historically, you see it goes in for PPS and then comes in for critical access hospitals. The emergency preparedness, the last reg is for everyone. This one right now is just PPS hospitals, but I would recommend that critical access hospitals work on meeting this with the idea that it will likely become required soon. And our survey indicates that the majority of hospitals have appropriate protocols in place already, so we're in good shape here. But if anybody has any issues or runs into any issues, we can regroup and help you work through those. So then I won't go through these. We already kind of have gone through a lot of these, but
Hey, Dana, just sorry to interrupt. There
no,
was a
please do.
question from Nicole. Any thoughts on how the policy should address the major delays in obtaining transport? I don't know if you have any insight on that, or if maybe someone on the call does. That feel free to hop off mute.
Did I stop sharing? What did I do?
No, you're good.
Okay, good. It did not specify in any of the regulatory things I read, nothing specified what that would look like. However, because we know it continues to be an issue, I would recommend but I would probably I always like policies that are a little bit more broad, but I would at least probably at least speak to the idea that there could be a delay.
Yeah, and we can follow up on Sydney with that too to see if she has any recommendations.
Yes, we sure can do that. Does anybody else address that in their policy that right now currently, or does anybody know if they do? Okay, well, we will follow up on that and get more information. But I guess in my mind, I would think that you would at least broadly want to touch on the idea that that is can be a barrier to transport, especially for the smaller hospitals. So again, I won't read through all of these specifically since they are, so this is the next grouping. So there's those two that are going to become effective July 1, and then the next grouping is a couple more, and they will become effective January 1 of 2026. So you're looking at the next 6 months. So the organization and staffing is a big one, and this is OB specific, and it just talks about kind of how you run your OB department, just talking about the standards of practice and training and scope of services and all of those kind of things. And the big thing about this is probably something you all already have. It talks a lot about having to document it. So make sure that you have an efficient and effective way of if a surveyor may come into your organization, that you can speak to this in a documented and standardized way. Oh, okay, there we go. Hold on. Why will my slides not forward? Okay, hold on, guys. Sorry. There we go. Okay. Um, this one again is another one that will be due January or will be effective January 1 of 2026, and it's the delivery of service. So it will just talk about having basic equipment for treating OB cases. Um, It kind of talks a little bit about what you'll have to have available, but it says readily available in accordance with the scope, volume, and complexity of services. So thinking about maybe a critical access hospital that only has one of each that you share amongst rooms, do you keep it in a centralized place that it can be accessed if needed for other people? So again, you just have to really document why it makes sense for your organization. And then as we talk about the OB emergency supplies like crash carts, boxes, kits, those kind of things, again, you just have to be able to describe to a surveyor why it makes sense for your organization based on the complexity and volume of patients that you see. And then again, we talk about having the protocols that were consistent with evidence-based practice, and then they talk about training. So it never in the reg says you have to have this equipment, this supply, etc., but you have to be able to speak to why you do or do not have certain things or why you chose the items that you did. So then the next grouping comes into effect in January 1, 2027. So then a full year, you have to do the rest. The staff training is a big one. So again, it talks about ensure relevant staff are trained on certain topics aimed at improving the delivery of maternal care. So again, they will ask you to have topics that reflect on the scope and complexity of the services you offer. So I think about like a Brian, it's going to be different than I'm a cook, a critical access hospital. However, there has to be rhyme to the reason. So saying why you do what you do. And there has to be evidence-based practice behind it, and the protocols have to show how they're going to improve the delivery of maternal care. So just talking about having that standard process for identifying what training topics you're going to have, and then making sure they occur on a regular basis. The other thing that is big on this, which there is actually a copy section, and we'll get to that, but they want to know that you are changing your staff training needs based on what your quality program shows. So if you are collecting quality data related to your obstetric programming, which you should be, you need to take that, analyze it, and figure out what areas need additional training behind them, and be able to document why you chose what you chose, and then be able to show that you did improve or that you're at least tracking data in the effort of improvement. And then it talks about new staff getting that initial training, and then there has to be records that prove that all of the staff completed their training, and that they do actually have the knowledge. They have to demonstrate the knowledge on the topics. So a lot of it will be documentation and making sure it's in their personnel record or wherever you would want to document that. So this is the QAPI piece a little bit. It just defines a little bit more what that was saying. This one also will be effective January 1. So again, it just talks about whatever your QAPI program is in your OB services area, you really need to base some of your training and education that will improve your health outcomes. So you need to analyze the data on your quality indicators, and it talks about a diverse subpopulation. A lot of us may not have a very diverse population, but you could even look at like a Medicaid versus a third-party payer or different things like that, just to be able to look at some subpopulations. And then we talk about measuring, analyzing, and tracking. And then this will help you analyze and prioritize where you're going to do your training and education to improve the care that you are able to give. And then it says you have to conduct at least one performance improvement project focused on improving the health outcomes and disparities among the hospital's population of obstetrical patients annually. So collecting the data, making sure you put a quality improvement project focused on your OB population in place annually. And so it talks a lot in there about leadership engagement, and really behind this comes just the idea that there is a culture of safety and quality, not only in the hospital as a whole, but specifically to your obstetric services program. So thinking about that more specifically. And then CMS is finalizing a requirement about the Maternal Mortality Review Committee. Nebraska does have a maternal mortality committee now. And Sydney and I talked about it a little bit. They do more of a kind of overall like learnings from the cases that they review, kind of a general thing that they're finding. We talked a little bit. They don't really necessarily work directly with the hospital that was involved. If there were some process improvement things. So just kind of talking through, but Nebraska does have a functional review committee, and they come together and review all cases that fall into their requirements. So this is, yeah, we talked a little bit about the phases. So we're coming up on phase 1 right now, July 1. And this just kind of shows the dates of each piece and when it will be due. So those emergent services and transfers are July 1 of 25, January 1 is the organizational staffing and delivery of services. And then January 1 of 27 are the training for the obstetrical staff and the QAPI piece. What questions do you guys have about the new regulations, comments, concerns, issues? Anybody? And Samantha did put some stuff in the chat for everybody to take a look at, but I will send out what she sends me via email to you guys too. So, but thanks for doing that. Looks like good stuff.
I can speak
Okay.
to our concern, I guess, and as a smaller facility would love to see if anybody's got some policies in place with treating those emergency conditions in the ER. I think that's our biggest hurdle that we have at the moment.
So are you, just to clarify, like if an OB emergency comes in, like how you would handle that, like to stabilize them?
Yes, I believe so. April, do you have anything else you can chime in from an OB standpoint? Is that what our biggest hurdle is, as far as you're aware too?
Yeah, I think it's more like the policy to it. I mean, I think we would know how to handle it, but like how does the policy look?
Sure. And just to, I guess, I don't know, clarifies the word, but even if you just make it kind of like a general protocol, and from my perspective, I would say just A1 or ACOG or whoever your best source of evidence-based practices is, even just, I mean, I think about like an ACLS algorithm or something like that, just something to help guide care so that if someone is working and isn't overly comfortable with an OB situation, like what meds, what those kind of things, I would say those would be a good start. And then for your policy, it can just be like refer to our evidence-based protocols to care for those patients versus like writing out a policy. Because like you said, you're going to know how to care for the patient, your providers are, but maybe just kind of like some algorithms or things like that might help them care for that patient.
I guess this is Michelle, and we're at Faith Regional. They're a little bit more of we have obstetrical services, but I guess I don't even know how to word this, but I mean, like when somebody comes into our OB department or into our emergency department and they would maybe have an OB emergency, they essentially are going to consult our obstetricians so I mean, is this more geared towards people that are going to be transferring patients out because they're not going to keep them there, or it's a little confusing? Yeah. I mean, reading the emergency services, I mean, they're going to stabilize patient, but they're going to consult OB and then have them handle probably the situation. They would move them obviously to our obstetrics unit. Then the provider, if they felt like it was something we would handle, or they would arrange transfer. And we do have like policies for like obstetrical transfers to a higher level of care. But
I think that's exactly how I would.
Okay, because that's what I'm like. I don't think we definitely. We don't necessarily have probably a policy per se that says we're going, I mean, kind of that process. I mean, when they come into the emergency department, obviously they're generally over 20 weeks and can be treated, they're going to be consulted to OB and then move upstairs, be handled there. Then the decision would be to transfer if they felt like it was something we couldn't handle. But
And that's why I think I'd
know.
maybe just put a protocol in place for your ED that's exactly at 20
Okay.
weeks, like consult OB and
Right.
transfer there. And then if you already have stuff in your OB department, then I think that would cover it.
Okay, it's just a little like when we are referencing just emergency, I'm like, oh, they're gonna consult the
Yeah,
people that know what's going on as far as obstetrical stuff. Okay,
absolutely. Your ED
what-
staff's gonna be like, OB, come get this person.
yeah, pretty much. I mean, whenever they have somebody roll through the door, they're pretty much. I mean, they'll obviously do anything emergent there that they have to, but more for the most part, they're calling OB to come admit.
Yep.
But wasn't there some information about like internal transfers too, like from unit to unit?
Yeah, and I was kind of
Digits?
looking. I don't know if we have anything like internally. I'll have to keep digging if we have anything specific to that. I know we have an obstetrical when it comes to like transfers to a higher level of care. I'll keep digging, kind of see if we have something somewhere that spells out.
And even just like stating the 20 weeks, like some of that, I know sometimes that
Yeah.
gets a bit hairy. Or if they come into the ED for an emergency that's not related to OB, however, they are pregnant, do they go to
They
OB?
do.
You know,
Pretty
those kind of
much,
things.
yeah. A lot of times they're
So-
calling OB in. I mean, those would be like, yep. It's probably, I would say for the most part, they go upstairs unless they needed it at like an ICU level of care. So,
Mhm. So yeah, I mean, just even outlining kind of something like that of how that would be handled, so that if somebody has a pregnant person come in, you know, they know what steps they are
Right.
to take with them. Yeah.
okay.
Other thoughts? Sorry, I got a message in here. The OB patient safety workshop link above takes me to a Brian Health login. I'm guessing maybe, and I don't know Samantha, but I'm guessing maybe you have to have an account to enroll in the class.
Excuse me, not necessarily. I'm thinking it's because I'm internal and it's not giving me the external link. So
Okay.
stay tuned, and whatever I send Dana will work because we have tons of people that are external who sign up for the class.
Perfect. Okay.
Yeah, I think it's probably just because I'm an internal employee and it's not letting me. So share the
Gotcha.
other one. But
Okay. Perfect. Okay. We will, yeah, but we'll get that out to you guys. So, other questions, things you want to put out to your peers? Does anybody know who offers also classes?
I thought somebody at St. Elizabeth in Lincoln still taught it, but don't quote me on that. I just thought that was something that because I know some providers were taking it, like LNEP docs that were going to go to rural facilities a few years ago.
I kind of remember that too, because I had a hospital reach out and that was one of the very few places I could find it, I think, was St. E's, and it wasn't very frequent. So, okay.
Right. I would maybe reach out to Rochelle Hesser if you're interested in it. If you need her email, let me know.
Okay, sounds good. Okay, anything else on these regs? Okay, so this next is just a really quick overview of what that severe hypertension bundle looks like. Again, to clarify, this is not regulatory driven, it is just best practice. And there are tons of implementation guides and different things like that out there. So I guess I will always say it makes sense to kind of follow these are evidence-based, they make a difference, and those kind of things. But even if you don't go all in and do every piece, just making sure you have something in place that surrounds that severe hypertension. It's the reason they create these bundles is because they are preventable concerns that are happening to our pregnant people right now that are creating an unsafe environment for those patients. So there's something to be said for just making sure you have a plan and addressing some of those complications that could happen to your pregnant patients. What did I miss? Oh, okay. Sounds good. Okay, we're still on that. Okay. So there are go ahead.
So you posted about the all the bundles, like you said, the hypertension bundle, the sepsis in the emergency department, we have to do education on all of those.
No, no. So those are just some ideas for ones you may have or you may put into place. Your organization can create whatever ones make sense for the work that you do. So my thought would be look back and see what you've seen, maybe historically in recent times, and then set a few up. You certainly don't need every single one of them. And they never specify what ones you have to have. They simply say you have to have evidence-based protocols in policies and protocols in place to address the complexity and scope of patients that you care for. So there just has to be, I guess, a reasoning behind why you put the ones in place that you did and educated on those.
So if
Does
you
that help?
don't do labor delivery, you just have to have enough data and stuff to show that you are stabilizing and shipping out.
Right. And basically just some protocols in place and like a kit or whatever it is that has the things in it. If either you're stabilizing shipping out, if somebody happens to come in and deliver in your ED, like maybe you're going to make sure you have a kit with cord clamp and all the things that would go along with the precip delivery that would happen really fast. So I would say normally, especially in smaller emergency departments for non-delivering hospitals, you'd want like an emergency delivery kit and then whatever you would need to stabilize and ship.
Sounds good. Thank you.
Yep. Other questions? And I was going to clarify that line listing is just like potential policies and protocols and things you might create. It is not a exhaustive list like you have to have all of these. It was just ones that maybe people would be willing to share or give ideas of ones that they may put into place. But it never ever states you have to have X, Y, and Z. It just says you have to have the appropriate ones for what you do in your hospital. Okay, so the AIM stands for the Alliance for Innovation on Maternal Health. And essentially, they just looked at all the data across maternal complexity and mortality and morbidity. And they said these are some key things that we see that could be addressed more effectively and would decrease the number of harms that happen to this population of patients. So MPIC takes kind of one, and I don't know how long they focus on it, but they look at data and they kind of work with hospitals on implementation for those bundles. And their current one that they're kind of kicking off and focusing on is the severe hypertension in pregnancy. So that is what just I'm working with Sydney, kind of talking about how we can support. So it doesn't like it not required, but best practice says these are some bundles or some things that you should kind of have a plan around. So they have each of these. So there's a readiness piece, a recognition, a response, a reporting, and a respectful. So there is a huge amount of information in these bundles. But even if you don't fully implement the whole bundle, just understanding that having a plan to address that severe hypertension is important. So the readiness piece, and I won't read all of these to you guys, but it talks about being ready in every care setting. So essentially have a process for management of pregnant and postpartum patients with severe hypertension. So protocols for the early warning signs, timely triage and evaluation of the pregnant and postpartum if they have some hypertension issues happening. And then for escalation, if something gets worse, what are we going to do for either a consult or a transfer? So being the readiness for that. So then it talks about kind of the key elements, the access to meds, the getting the correct people in the room, referral resources and communication pathways. So we think about even just that transfer plan. And then they talk about there's a lot in here about the trauma-informed protocols and like being equitable to all patients. So there's kind of a piece of that in all of this too. Then the recognition and prevention. So this talks about every patient. And the key elements of this are having a plan for assessing and documenting the patient if they have been pregnant or if they are pregnant or have been in the past year. So again, assessing, because that severe hypertension can happen postpartum. So just understanding when they were last pregnant, and then having good training, because this would be actually a good training protocol for those of you that have OB is making sure you have accurate measurement and assessment of the blood pressure for that pregnant and postpartum mom and how that might look differently and what a normal reading would be and those kind of things. So, and then they talk again about the social drivers of health, education to patients, and then making sure your healthcare team understands the additional signs, symptoms, and treatment of that severe hypertension. So if we've got to recognize be ready to deal with the patient, recognize that they have it, and then know what we're going to do for that patient. Then the responses every event, again, the key elements talk about standardized protocols, checklists, escalation policies. So again, knowing the early warning signs, observing symptoms or asking about symptoms, and then what labs you would maybe want to draw if you have a potential patient. Postpartum follow-up to occur within 3 days of the birth hospitalization, for those that had a complicated hypertensive disorder. So if your follow-up once they're discharged is beyond 3 days, for your normal healthy deliveries, you'd want to, per evidence, say that somebody that had a complication with severe hypertension would want to be seen in 3 days after they deliver. And then again, we talk about the trauma-informed support and how you can make sure that the patients are getting the care that they need in the way that they need it. Reporting and systems learning. So this is every unit. Just talks about huddles, multidisciplinary teams, post-event debriefs if you need it. And then talking about any opportunities for improvement, because this would be another one that maybe you would drive a QAPI plan around based on what the new reg is. So if you're seeing some patients with some severe hypertension and you find out that maybe a piece of the bundle or the process isn't going like you planned. So if you're collecting data around this, then that would be an easy process improvement plan that would fall into the required regulations. And then again, looking at your outcomes and process data to make sure you made a difference. And then the respectful and supportive care. This just talks about every patient is a little bit different. We need to be empathetic and communicating with our patients and just identifying where their support comes from. And then making sure that you have the pregnant person and their support system as part of the team. Make sure they have shared decision making when it comes to the care of that patient. So those are kind of the key just pieces to it. Again, there's lots of resources around it, and you can go to the link. They have lots of stuff on their website, but the idea behind it is that you have a good standardized plan for caring for patients that are pregnant and having potential hypertension complications. So that is all I have for you guys today. What questions does everybody have? None? Nothing?
I honestly think, Dana, this is Sam. I honestly think it's probably really overwhelming for people. They don't even know what they need probably at this point, if I'm being honest. And even being a big OB hospital, I mean, I could read into a lot of these and think, oh gosh, I need to work on all these different types of things as well. But and reality is, I think we just can't overthink it right now because it's just so much. I mean, you even talk about the AIM bundles. We've been doing that hypertension bundle for 5 years and it evolves over time and we're still doing it. It's not gonna, there's no end in sight basically for hypertension. And the OB hemorrhage one that we're kicking off in June with NPIC, I think the goal is to have a 2-year turnaround. But then AIM goes and they update the bundles every few years. So there's always something to work on. So I just want to let people know, I mean, you're not going to be perfect and you do the best you can with what you have. And I think focusing on the evidence-based practice is important. And again, knowing the why behind why you're doing what you're doing is going to be the important piece.
Very good. Yes, I agree. And that is one of those things. There's no, I guess, idea that there's perfection or that. I mean, we know in medicine everything's changing. So but I think that's kind of the beauty of the new regulations. It just wants to make sure you're looking at your quality and you're doing what you can to try and improve that. So making sure that there's just a focus on actually digging in and seeing how you're doing and then how you can improve that care. So that's what we all want, is to give the very best, safe, effective care that we can. So I think that speaks to that. So I appreciate your thoughts on that.
That's
Yes, I will.
Donna.
So once this,
Cool.
oh, sorry, whoever I cut off, go ahead.
Sorry, it's Donna. Hey,
Hi,
from
Donna.
Syracuse. I was wondering, on the OPS class, is that something that would be done like every 2 years, or is that like a one and done certificate, and then you just try and um, do your annual education on other sims or whatever? But can you give us just a little bit more information on that?
It's 8 CEs and it does account for the Joint Commissions, exactly kind of how CMS is talking about. You need to have these defined factors for every 2-year education. That does count for that 2-year education. So it also counts for, it has CMEs for providers and CNEs for nurses. So yes, you can do it every 2 years, or your facility could take it once and then you could kind of take that information and make it your own for every 2 years. No, it's not required every 2 years by any means, but it is kind of one of those highly recommended things. I think if everybody wanted to take it every 2 years, it'd be completely overwhelming for our instructors, obviously. So, we're not even mandating all of our nurses here at Bryan take it, because when you think about that, you think about at least 200 nurses just within our Bryan Medical Center walls, just in OB. So even to think about other people having to take it would be overwhelming, because I think less than 20 people can take it per time, because you go do active simulations during it. It's very hands-on environment and there's pre-work, so it's pretty intense, but it gets the job done in 8 hours. So
Okay, thank you.
And yes, the slides, so once the recording is taken off of my Zoom and Comms does its beautiful work with it, we will put that along with a copy of the slides on our website, and I will just send out the link to where that will be found, and you can access it and share it with others in your organization that may find it beneficial.
Yeah, so we'll also include that Dropbox link on the website too, so we can peer share. There is one policy in there already, so thank you for sharing.
Yes, and to Amber's point too, we are working on kind of creating I don't know if you want to call it like a final report of that gap analysis and just sharing thoughts, and so kind of putting that into one useful document. But anybody that's on here, even if you didn't do the gap analysis and you have things that have worked well or you have protocols, please put them in that Dropbox, because that's the beauty of Nebraska healthcare, is everyone shares, because we really just want everyone to give the best care they can. So that would be helpful if you have anything that you'd like to share. Anybody else have any closing thoughts before we sign off? Just a follow up. We will probably try and pull something together, just like maybe like in November, to kind of talk through anything that's changed, and then those upcoming January effective date of January 1, just to make sure everybody's feeling okay. So we will likely put something together just to talk about that, and then any changes that may have occurred from that perspective. So otherwise, I think we are done. We'll give you guys back 9 whole minutes of your Monday, and we will be sending out more information and resources. So, and if you think of anything else you need, don't ever hesitate to reach out to Amber and I. We're happy to help or certainly connect you with the right folks. So thank you guys, and we will talk soon.